Okay, so let's go on and talk about instability now. So there are a lot of different ways to categorize instability. One is to use the term microinstability, macroinstability, I'm sorry. That's the usual one people talk about. It involves the glenohumeral ligaments, the labrum, capsule, and bones. And then there's another category which some people call microinstability. It's an Orange County term. And it primarily involves the superior structures that we'll talk about. So you're all aware of the anatomy. Here's the glenoid. The humerus is removed here. We can see the anterior labrum is here, a superior labrum, posterior, inferior labrum. This is the insertion of the anterior band of the inferior glenohumeral ligament. Its insertion can be very high, or it can just go up part way here. We'll talk about the high insertions and their potential problems later in the talk. And then the middle glenohumeral ligament attaches over here more immediately on the anterior glenoid, okay. If we take it cross-sectional area, like on our axial images, here's the subscapularis muscle and the tendon, which attaches to the lesser tuberosity, as you know. Then we have the capsule here, and a thickening in the capsule in this location is the middle glenohumeral ligament. Typically goes from superior inferiorly down, and then it really attaches to the deep subscapularis fibers, as we'll talk about. And there's the anterior labrum, posterior labrum, and then there's the posterior capsule back here. So on an MR scan, this is what it looks like, an old MR scan. Here we can see the subscapularis muscle. There's the tendon attaching to the lesser tuberosity. As you all know, on the other side of the biceps is the greater tuberosity. The middle glenohumeral ligament is right in through here. It's a thickening of that anterior capsule in this location. Then there's the anterior labrum, posterior labrum, and the posterior capsule back here. So it's pretty straightforward, except for the anterior superior area where the anatomy gets more difficult. The anatomy is difficult there because the supraspinatus, infraspinatus, and teres minor tendons are all contiguous with one another. As you know, in fact, the supra and infra overlap a lot, which we talked about in the when we talk about supraspinatus tendons. Then there's a gap between the supraspinatus and the infraspinatus, as you all know, because of the coracoid process. And then we have the subscapularis tendon here. So in that place in between, or around the coracoid process, we've got a little bit more complex anatomy that has a lot of variations to it. That we're going to talk about some of those variations in a minute. So if we look in the axial plate in that anterior superior area, here we can see the anterior portion of the superior labrum. This is the superior glenohumeral ligament over here. If we go on the sagittal plane, this is that middle glenohumeral ligament, which comes down and it really attaches to the deep fibers of the subscapularis. Then there are the different fibers of the superior glenohumeral ligament up in this area. And there's an interval in through here where you have, between there and there, where you have no rotator cuff. You have the anterior margin of the supraspinatus, superior margin of the subscap, and then you have this gap, which is the rotator cuff interval that you're all familiar with. Posteriorly and superiorly and posteriorly, it's all continuous. So that's the interval there. So there's the labrum. Here's the superior labrum in that location. And then middle glenohumeral ligament, and then the superior glenohumeral ligament over there. So there are a lot of anatomic variants. You can get labral recesses. Now, below the equator, there's supposed to be no space between the labrum and the glenoid. So if you see fluid deep to the inferior labrum, that's considered abnormal, and you have to be concerned about a tear. Above the equator, you can have what are thought to be normal recesses. Though there are a number of people who feel that you're not born with these, they kind of developed as people age, may have something to do with the amount of motion that occurs in the superior labrum. But as long as it's nice and smooth, it's not considered abnormal to have fluid going deep to the superior labrum. We'll talk about that later. In this area of the rotator cuff interval, you can have a defect in the labrum, which is called the sublabral foramen. And it's typically thought to be at about 19% of people, but depending upon how you define what a sublabral foramen is, it can be a lot more than this. Associated with this, you can have a Buford complex, which we'll talk about. I think Buford was a fellow at UCLA who did about 200 cadavers and found this a defect in the anterior superior labrum associated with thickened middle glenohumeral ligament in about 6.5% of the cadavers. And then you got the superior inferior glenohumeral ligament insertion, a superior insertion, which we'll talk about, which can be confusing. And then you can also get plica in this particular area. So above the midline you should have no labral. Above the midline, you can have a inferior labral recess. Below it, you're not supposed to. So here we can see this is a T2-weighted coronal, a PD fat sac coronal, and here's the superior labrum. We're getting in the area also where a part of this is going to be the biceps anchor. And we see a little bit of fluid collection here going deep to the labrum. Here's the articular cartilage. There's a surface of the articular cartilage. And this would be a very small, normal superior recess right in that location. Okay, let's see. Robert, what do you think of this case?
All right, so we have a 4-year history of shoulder pain from calcific tendinitis. Looking at that superior labrum, looks like a pretty smooth contour, so I think it's still another recess there.
Okay. And then here we can see it on the axial images, and that's a superior labral recess. Now, there are papers a number of years ago that looked at the thickness of the superior recess to see whether the thickness correlated with whether arthroscopically it was called a tear or not. And the thickness actually did not correlate. So you can have normal recesses that can be 4 or 5 millimeters. So the thickness is important. What they found was the most reliable differentiation between on MR between a superior recess and a superior labral tear was if you saw increased signal intensity going definitively out into the labrum itself. That highly correlated with the tear and not just a normal recess. So that's what you look for a superior labral tears. And that was a big deal, and we'll talk a lot about typing superior labral tears. I think later in this particular talk, and we'll discuss the significance of that. Okay? Superior labral recess. Okay, what do you think of this one? Well, yeah.
All right, so image on the left. There is some fluid undermining that recess, but it also extends more laterally. I'd be more concerned that this is a tear.
So there you can see that. And if we go, now I'm going more inferiorly, what do you see here?
Looks like there's separation of the labrum.
So here, now this is pretty high up. This could be getting into a sublabral foramen that we'll talk about in a minute. But now we're down more inferiorly, and here's the articular cartilage here.
Yeah.
So this is clearly signal within the labrum itself.
Yeah.
And that lets you know that that's more likely going to be a tear. And down here, we're out of it at this point, but this was a documented superior labral tear. Actually, tears in the superior labrum are pretty uncommon. The There was a while when these were treated aggressively that often overly constrained the shoulders, and the patients didn't do very well. So in this, just 1 second. Hi, I'm lecturing. Can I call you back? Okay, bye. Sorry about that. But this was documented superior labral tear. But you have to be very careful about repairing these, not to overly constrain the shoulder.
Okay, 52-year-old male, increasing pain for 9 months, ruled out impingement. Looking at the superior labrum on the coronal view, I see a sublabral recess. I mean, there could be some increased signal, but it's not really clear.
It could be cartilage. Well, the cartilage goes up through here.
Okay, yeah.
It's not quite as black as we'd like, but this also is not a great quality image. There's a lot of poor signal from eyes.
Mm-hmm.
Okay, so this is 6/18/05. This is now 12/20/07. What do you see here?
Okay,
Same patient.
so again, on the coronal view, you see increased signal going along the cartilage. I mean, yeah, it could be just the cartilage. It could
Nice
be a.
smooth cartilage. No significantly abnormal signal going out into the labrum.
Mm-hmm.
Okay, this is 12/20. They were concerned about a labral tear here. Okay.
Okay, so more inferiorly on the right. Is there some fluid there undercutting the labrum, or?
Yeah, that's right. Okay, so this is 07. This is 08.
So again, undercutting it, there's regular cartilage, maybe some fraying of that superior labrum on the coronal view, but
Yeah.
nothing really distinct.
So this was, okay, so this is, wait, let me make sure I got this right here. Okay, this is 10/21/08.
Mm-hmm.
Okay, so here we get these images. Here we also have 10/21/08. What do you see here?
Looks like has there been some kind of repair in that anterior glenoid?
So this is a suture anchor, so you're right. Right here we have a normal kind of recess or sublabral foramen. There was a suture anchor that was placed there.
Mm-hmm.
And after surgery, the patient's symptoms actually got worse. And this was actually a surgical repair of a superior recess. And but it overconstrained the shoulder, and the patient did not do well.
Mm-hmm.
So if we go back again here, not a great image, but I certainly wouldn't be willing to call it tear here, because again, I happen to believe that the biggest problem in MR imaging of a lot of these joints is overcalling pathology and creating unnecessary surgery. We've already talked about going through that, what happened in the knee with meniscal tears. And we went through the same thing with superior labral tears, where a decade and a half ago, these were all the rage, and a lot of surgery was done. People made a lot of money, but the patients didn't do well. So, and this, go ahead, John.
This guy is 52 years old, and the lesion that you see there, that it looks very innocuous. Doesn't look like there's anything substantial. But if you look at a supraspinatus tendon, that's where your pathology is.
Yeah, this isn't quite windowed to see the supraspinatus very well. Maybe you're right.
Yeah, I know, but I mean, it looks like it's frayed in that area, and maybe partial tear. But that looks worse than that
in the
labral area.
Anyway, so this wasn't called a tear. They didn't do surgery at this time. Came back again. This was called a superior recess. The biceps anchor looks fine. The superior labrum actually looks pretty well. And then but as we can see there, but this was called a superior labral tear. Again, I think this fits all the criteria for a normal superior recess. Patient had surgery, and it didn't work out terribly well.
Well, the radiologist missed the boat.
Okay.
And if you look at the left image, the fat sat image, there's a cyst in the bicipital area.
Yeah.
Oh, wait a minute, that's not bicipital.
That's at the insertion of the
Yeah.
anterior part of the
Right.
supra. Yeah. Okay.
And so I'm not surprised that this patient had a problem because they operated on the wrong area.
Yeah. Who's next? Okay. So we're concerned about the labrum. What do you think?
I mean,
Um,
I think that's the superior labrum. Looks like it's a.
So this is right about the midline. There's the labrum. We go below the midline. This is what it looks like. And this is partial volume of the origin of the middle glenohumeral ligament. We can see the middle glenohumeral ligament going down there. Here's the labrum just a little bit below the midline.
I think it looks okay. I mean, it's thickened a little bit, maybe, but
Yeah, well,
it looks okay.
There is a little bit of fluid undermining the labrum here,
Oh,
which
okay.
shouldn't be normal. I say shouldn't be normal
All
because I
right.
think sometimes it can be, but you have to be very suspicious and look carefully for a tear when you see fluid down below here
Okay.
undermining it. And if we go to the coronal images, we can actually see that it's undermined right here inferiorly as well. And this patient went to surgery. They had a strain of the middle glenohumeral ligament here, and they thought that the labrum was way too lax and probably was a tear, but it was an incomplete tear, and they actually didn't do any suture anchor repair.
Okay.
That looks pretty kind of an unusual labrum in that area, John.
I agree with you.
Why did they operate on it?
They did, but they did not do any repair of the labrum.
I suppose they wouldn't. I mean, well.
Yeah. Okay.
Sorry, go ahead.
Yep. So, Robert, what do you think of this case?
All right, so we have an axial. And looking at the anterior labrum, it looks like there's a tear at that base of the labrum.
Right down here.
Yeah.
So you're concerned about right there.
Yep.
This is actually, notice how smooth everything is here. It's the anterior superior part of the labrum. Be very careful about calling tears in this area. This happened to be a normal sublabral foramen. And the structures we're seeing here, there's the bone, here's the labrum, here's the articular cartilage, this is the sublabral foramen, and this is a thickened middle glenohumeral ligament right there. And if you follow it down, the middle glenohumeral ligament will fan out and insert to the to the posterior surface of the subscapularis tendon here. So this is really normal anatomy. And sometimes you'll see these three structures. There's a lot of variation to the middle glenohumeral ligament, and there's a lot of variations to that anterior superior labrum that we're going to be talking more about. Okay, so here are a bunch of images on the same patient. Here we can see the biceps tendon come over to the biceps anchor, superior glenohumeral ligament coming out here. If I go a little before that, we see a structure here. And if we look at this, we can see there's that structure coming down. And if we follow it coming all the way down, it goes to there. And then if we follow on the sagittal images, it starts up high, comes down, and see it fuses with the subscapularis tendon, and this is a thickened middle glenohumeral ligament. And I want to show this to you because you've got to recognize it, because one of the variants we're going to talk about in a minute, the thickened middle glenohumeral ligament, is part of the definition of that. And if you notice here, if you follow this down, this is the middle glenohumeral ligament, which means there's no anterior superior labrum here, right? So there's really
Well, one thing to remember also is, John, I'm sorry to interrupt. These ligaments are actually capsular. They're also called anterior capsular ligaments. So they're uh, basically fused with a capsule, and so that can be thick or it can be thin.
Yeah.
And there's a great variation in these, as John has told us already.
Yeah, we'll see a lot of areas where there are ligaments that are named, but they're really just thickenings of the capsule. We'll see a lot of those in the wrist as well. And this complex is called a Buford complex. So just be aware that this is considered normal anatomy. It's a variant. As you saw there, some people believe it's around 6.5% of people. So you should be seeing this almost every day. Okay, let's see. Tayson.
All right. 8 months post labral repair. I think there's maybe some irregularity of the anterior superior labrum, but no focal defect.
Okay, there. So we keep finding we're going up now. Go up again here.
Okay.
There. Okay, what's the yellow arrow?
I guess it's our middle glenohumeral ligament.
And
And
we
then
don't
we have
really see an anterior superior labrum, right?
Yeah.
Go up here, and what do we see now?
We see a cervical tract in the glenoid from maybe a prior.
And then what's
labral
this?
repair.
What's this over here?
Our middle glenohumeral ligament.
Right. There's no anterior superior labrum. And then, say, coming across here, there's that dark structure coming down in the coronal view, which is the middle glenohumeral ligament.
Yeah.
Here we can see there's a superior recess, and there's where the suture anchor is. And this is someone who had a surgical repair of a Buford complex. So, it's important to recognize these. This was a time when it was really the hot thing to repair these superior labral tears. I haven't seen this kind of thing done in a long time now, but the way you word your reports is going to have a significant impact upon what kind of surgery people do. So it's important to recognize the normal anatomy and the variants.
One of the things that should be done in shoulders, and that's recommended pretty much by everybody, except people that are in litigation, wait 2 or 3 months of conservative treatment before you start thinking about MRIs and doing surgery, unless it's some injury that's significant.
Good.
Okay, so 20-year-old baseball player, rule out labral tear. So I think we're above the equator here.
Yeah.
Anterior superior labrum is not well visualized.
Thing here.
Mm-hmm.
Okay.
Anteriorly, there's maybe that's the middle glenohumeral ligament that's thickened with some signal in it. Yeah.
Yeah. So that's it. And if we go farther down, this is a tear in the middle glenohumeral ligament. Not common, but This thickening here and there. You can see, again, you can confirm that the middle glenohumeral ligament very nicely on these sagittal images because we see it fusing with the deep subscap.
Mhm.
So that's a patient who had a Buford complex, but had a tear of the middle glenohumeral ligament. Okay.
So, patient has a pain after a falling injury, catching himself while falling. Um, so on the left, we have an axial image. Looks like there's some increased signal at the anterior glenoid. Um, I th it almost looks like there's a like an osseous defect there as well,
Where?
like a little bit anterior to that.
Up here?
Yeah, like
What's
that.
this?
Like a that looks. Oh, it could be the. It looks like a piece of bone, like in a.
Well, what do you see here? See, the sagittal images are actually helpful in figuring out what a lot of this anatomy is.
So there's some edema there, and then that.
But notice that this, whatever, it's a linear structure. Generally, it's very serpiginous here.
Yeah.
Usually, linear structures in the body are straight or
So
gentle curves. And in there, what sits in this area anatomically? Could be labrum.
yeah, it could be labrum, or it could be the middle glenohumeral ligament.
Okay. This is what it looks like surgically. That looks like something that's torn. Looks like it's intact, and that's what a tear looks like arthroscopically. And this was a tear of the middle glenohumeral ligament.
Okay.
So if we go back here, that's actually a tear of the middle glenohumeral ligament. And here, the ligament tore, it inferiorly displaced, and it's all crunched up here, and that's where the tear was. And this is surgically confirmed from Dr.
And that's edema, isn't it, John?
It is, that's right. So that's what it looks like. Okay. Robert.
All right, so we have question of a tear. Looking at the anterior labrum, there's a little bit of fluid interposed between what I think is the labrum and the anterior glenoid,
Okay.
but I'd want to see it on multiple images.
Okay, so posterior labrum, all right. Here are multiple images. There you go. You got your wish.
I don't think that's a labrum. It looks like it extends into the capsule. Is that just a middle glenohumeral ligament?
Okay. That's a subscript. So this is what's called a cord-like middle glenohumeral ligament. But it's focal thickening. Sometimes you can see fluid going all the way around it, but it's focal linear thickening of the middle glenohumeral ligament. And this is sort of thing you see in a whatchamacallit, lesion. Buford complex. Thank you. I got Buford. Hopefully he's not going to listen to this lecture. Yeah. So that's a cord-like middle glenohumeral ligament. Okay, we saw this image, I think, before. Just go through the anatomy again. Middle glenohumeral ligament in the sagittal plane comes down and fuses with the subscap. And you can get an axial image right through here, which can be confusing. Now, Tayson, this was a potential #1 draft pick college football player from a well-known school in the southeast part of the United States. And he came out for evaluation because he had shoulder pain. And there was some concern about whether he'd even be drafted, much less #1, because of the way this MR arthrogram was read. So how would you read it?
So I think what we're seeing more anteriorly is a thickened middle glenohumeral ligament,
Okay, so there.
and well, the cartilage looks
What's happening there?
um I think the structure projecting more into the joint spaces are labrum.
Okay.
I'm not exactly sure what
Okay.
that
Good.
is.
Okay, now then, let's start from the bottom and work up. There's the bottom. So this is the inferior glenoids. What do you think these things are?
Um, is that inferior glenohumeral ligament?
Okay, this is the
Middle.
anterior band of the inferior glenohumeral
Okay.
ligament. Now, it can have many different shapes, which was a problem in the early days when we are trying to figure out the MR of the shoulder. But this is what it looks like at the very bottom. And then let's follow it up. There it is up. Now,
Right.
usually it inserts on the inferior part of the anterior rim of the glenoid.
Yeah.
But here, if we follow it, it goes all the way up to the top here, all the way up to there, and all the way up to here.
Okay. So
And if we go to the sagittal images, we have this structure, we have that structure. So what are they?
so we have a like a high insertion of our
Okay.
IGHL.
So this is a superior insertion of the anterior band of the inferior glenohumeral ligament, which is a normal variant. And this is the middle glenohumeral ligament coming down here. And so we got back to the player and to the NFL saying that he just had a normal variant of the shoulder. It wasn't a torn labrum and did not indicate that he had a surgical instability. And he was drafted high up.
How much they pay you, John?
Not enough.
That's what I figured. Bunch of cheapskates.
I've gotten a few letters from well-known players thanking me in the past, which was nice.
At least they could
Not
send you
favorite checks.
on vacation or something.
What?
At least they could send you on a nice vacation or something.
Yeah, right. Okay, let's see. Let me see. Other things that you can see here. This comes from Luis Cerezol from Spain. This you can see some abnormalities posteriorly. We can see a labrum undercut here a little bit, but you can see the soft tissues kind of blend into the joint space here. On the coronal images, we can see this linear structure in the coronal plane with contrast behind it and in front of it. Excuse me. Following it all the way down here. These are number of cases of shoulder plica posteriorly here. I haven't seen very many of these, but this was a nice case showing how a posterior plica can also have some look confusing, but just be aware that you can have a posterior plica as well. So let's go on and talk about labral tears, talk about some technical issues, anatomic variants, and a little bit about different tear types. So one thing, one of the early people adopters of the ABRA view was Philip Tierman, who you guys are working with now. This is an arthrogram. The ABRA view is where you put the shoulder in the abducted externally rotated view up above the head. Again, initially this was thought that it would put traction on the anterior capsule and pull the labrum away, and therefore make the anterior labral tears more visible. And we can see that in this particular case. We don't see an anterior labral tear on the regular views. Put them into the ABRA view, and we can actually see that anterior labral tear. So at first, this was thought to be able to increase our sensitivity for anterior labral tears. We did a series of about 200 of these, comparing them, and it turned out that it actually obscured more labral tears than it helped. Because also, if you put tension on this anterior capsule. And some people's, what it will do is pull the labrum back to its base again and actually obscure the labral tear. So you can have it really go both ways. That's why you have to look at both. It does give you a lot of ability to look often at this posterior superior portion of the joint space, which we know is an area of internal impingement that athletes get, that we've already talked about. But anyway, I would only do these in athletes because you have to basically do 2 studies. You put the contrast in, you do a regular study, and then, for the reasons I just said, you have to do both. And also for looking at all the other parts of the anatomy, we're much more used to having the shoulder in the anatomic position. And then you have to take them out, reposition and put on a different coil, put them back in the scanner and rescan them again. So it takes double the amount of time on the scanner. Because we have to use a non-shoulder coil typically to get these, the signal glenoid isn't so great on the ABR often. So we tend to not do these at all anymore. There are in some athletes, you might want to do it. There are some people who do them routinely, but not very many in this day and age when there's more and more pressure for throughput and so forth. But there are a number of people who are really trying to push sports medicine who like to do these and really feel that they're important. I found that sometimes, fairly frequent, well, we found that only it really impacted the diagnosis about 1% of the time in the study that we did, which in 200 patients is not very many patients. So I felt that it's rare that it was actually worth spending the time and effort to do that imaging. But there are a number of people who would disagree with me. So who's next? Okay.
I mean, that does disagree with both of us.
Yeah, John says that if they can get in the ABR view, then they don't need surgery anyway. I can tell you from personal experience that if you have shoulder pathology, one of the most painful things to do is to lie in an MR scanner. And I don't know why, but it's very painful the way the coil's positioned, and it's actually pretty painful. And when I didn't have acute shoulder pain, I could lie in just fine. But when the pain flared, trying to be still in an MR scanner is a very agonizing thing.
Yeah, that's why I don't raise my arm in that position. Besides that, the hips are the same thing. You do the ABR position, and that hurts.
Yeah.
Unless you're a really loose guy or girl.
Okay.
Okay, so labral tear. Looking at the anterior labrum, I'm not seeing a tear. Maybe some fraying there, but
Okay.
that's it. That
This
looks
little thing here.
like cartilage.
I
But
agree. I agree completely. That's the ABR view.
ABR view. Okay, so anteriorly, I think we see some
Yeah,
fluid.
it's flipped around when you go to
Right.
the ABR view.
Right.
So this is the anterior labrum. This is the anterior labrum.
Right, so anteriorly we see fluid undercutting the labrum.
Yeah, so this is one of those 1% cases, like 2 cases that we had, where we could pick up the labral tear on the ABR view, but we couldn't before. So it does happen with the ABR view. It really is helpful, and you can see some thickening of the periosteal attachment that we'll talk about later as well. But this was only in like 2 cases out of 200 that we did. So, okay. I think we might have had one other one too. Okay, Yvonne.
Okay, so we're looking at an axial image or axial images. So it looks like there's some possible discontinuity of the, I believe that's the anterior labrum right there.
So right in here, this was actually a patient, but not in that particular study that we did. And here on the labor view, that's what it looked like.
Okay.
And it's still, it was suspicious on the regular one. There's suspicious here, but it doesn't really look like it displaced. And at surgery, this patient had an anterior labral tear. So here, the ABR view, again, was suspicious, but not definitive. And then if you look at a lot, this is a normal labrum. This is the normal cartilage at the base of the anterior labrum. Here's a labral tear. It's actually out in the periphery of the labrum proper itself, separate from the articular cartilage, which is down here. Here's another labral tear, basically articular cartilage here, a separate area of high signal intensity, which is the tear in the anterior labrum. And then here's an anterior labral tear that's really in a different direction. I think this patient had an unstable shoulder who probably had an anterior dislocation and sheared off the anterior labrum in that particular direction. So the yellow was normal. The reds are all different kinds of anterior labral tears. So let's talk a little bit about the osseous anatomy, because for stability of the shoulder, but the bones and the soft tissues are both very important. So typically the humeral head, if you look at the humerus, you have about a 20 to 30% of retroversion. If you draw an angle between the long axis of the humeral head and the center of articulation of the humeral head, the articular surface is about 45 millimeters, radius between 20 and 25 millimeters, and a group of patients studied at Curl and Jobe. You typically have an inverted pear shape in the sagittal plane about 90% of the time, ovoid shape in about 10% of the time, and those are the typical dimensions. As you look at glenoid version, the way you define it really is in a cadaver, you take out the scapula and you look at the long axis of the scapula and find the angle between a line drawn along the long axis of the scapula and the face of the glenoid, which we see here. 75% of a large group of patients were retroverted, an average of about 7.4 degrees in relation to the plane of the scapula. Increased glenoid retroversions increases the risk for posterior instability and is generally associated with congenital underdevelopment of the posterior glenoid. That's usually associated with increased size of the posterior labrum, which we'll talk about. Increased anteversion is seen in patients with increased risk for anterior instability, which, as we all know, is the most common instability. So this large degree of retroversion is typically indicative of congenital dysplasia. And here's just an example, congenital dysplasia. You could draw basically a line along the anterior glenoid, a line from the medial aspect of the scapula through the center of the glenoid, and this angle is, in this case, is 50 degrees, but 90 degrees would be 0, so this is actually 40 degrees of retroversion. Who's next?
I can go.
I think it's me.
Yeah, I think it's Robert too.
Uh,
Elior is trying to hog your view.
let's see. It looks like the glenoid here is retroverted quite a bit, and then posteriorly, is that the labrum that looks thickened and torn?
Yeah, so you basically see that the posterior half of the glenoid just isn't there. That's what this is. Very small glenoid, severe retroversion, and then this is the compensatory large posterior labrum that you get in these congenital variants of the glenoid. Fortunately, these congenital variants are not as common as anterior compartment of the knee, because these lead to marked instability of the shoulder. John?
And this anatomy is quite abnormal.
Yes, it is. Now, the interesting thing about this is that this allows patients to have increased mobility, and therefore this kind of, maybe not quite this severe, but congenital variations of the glenoid are seen disproportionately in young Little League pitchers. And I think if you remember the lecture we had a few weeks ago with Curlin Joe, one of the things they were talking about in Little League pitchers is having large posterior labrum and kind of a shallow posterior glenoid. Those are people with congenital dysplasia. The problem, it turns out, in those people trying to be athletes is you put a tremendous amount of strain on the posterior labrum, and they are highly prone, probably in every case, to have a tear of the posterior labrum, because you really need bony stability posteriorly to really be able to be stable under the kind of strains and stresses that you get in athletics. Time.
The head doesn't look round enough. It looks like congenital anomaly.
Yeah, this is a congenital anomaly. That's right. And there you can see the tear at the base of the large labrum. And then, so it's congenital instability. Here would be a less severe one where you have a large posterior labrum, blunting of that posterior margin. And again, these are the kind that you'll often see in the young baseball pitchers. And as long, we also can see this, I think, in older baseball pitchers and weightlifters, especially bench pressers, who will repetitively have trauma posteriorly here and will kind of wear away, or maybe even multiple impacted fractures, produce an acquired deformity of the posterior glenoid where it becomes more rounded, and they tend to have posterior instability as well. How much of those are actually Wolff's Law, right? How many of those are actually congenital dysplasia that we just pick up in an older age, or how many are actually acquired? I don't think anybody knows. I don't know of any studies that have really looked at that. But they're kind of they end up in the same location where you have abnormal anatomy and posterior instability. Let's see, who next?
I got it.
Yeah. Okay.
All right, so we have posterior subluxation of the humeral head.
I would call this a dislocation.
Dislocation of the humeral head, and then there is
there's the glenoid.
Congenital dysplasia of the posterior glenoid.
Yeah. So you have more severe congenital dysplasia and chronic posterior dislocation in this particular case, all from congenital dysplasia.
Here again, I think I would look at the neck, cervical.
Yeah,
Yeah.
Not a bad idea.
Pardon me?
Not a bad idea, John.
Yeah.
So, okay, on these radiographs,
I know all you guys love plate films.
yeah, well, I think we have a dislocation again.
Yeah.
I don't know.
So this is another patient. This patient was markedly unstable.
Yeah.
And so this is the
Go
ahead, John.
Definitely abnormal.
Yeah. Okay, x-rays. Here's the MR.
Well, it's hard to tell what's normal here.
That's a low field scanner.
Yeah.
Here's the glenoid.
Yeah.
There's the humeral head, markedly irregular, big effusion associated with this.
Right.
And this was severe congenital dysplasia. Come on.
So we're looking at an axial image. The glenoid appears grossly normal in morphology. There's thickening at the of the labrum.
Anteriorly
I believe that's anteriorly.
So this is a PD fat side image, and over and over again this year, you won't be here for the whole time, but I will say that it's really important to look at the images where you have fat. Because, and I don't understand why some radiologists will get all fat suppressed images, because the best contrast agent we have isn't gadolinium. For the musculoskeletal system, the best contrast agent we have is fat. And this is what the T1 weighted image looks like.
Okay.
So what's happening there to that anterior labrum?
So we might have some like fatty degeneration or.
Yeah, this is ossification of the anterior labrum.
Okay.
So that's just, so this is all one big bone here. And that's the fat within the bone, which is suppressed with fat suppression.
Okay.
And this is indication that you just have a severe degenerative disease of that labrum. And when you go in there, it's just all bone. And here we can see ossification of the inferior labrum as well. John?
Yeah, the head is deformed also, so this is
Yeah.
I don't know if I would want to operate on this case.
Yeah, well, you might end up, patient will probably end up having to have a joint replacement. But there you can see on CT the ossification and a little ossification inferiorly as well.
When I see these congenital types, you think about achondroplastic dwarfism, which is quite common.
Yeah.
And you see a pathology like this.
Yeah, well, this patient is on the older side of things, but right, good. Okay, why don't we stop here, and tomorrow we'll pick up and go through the different kinds of labral tears. Okay, thank you.
Thanks.
Have a good one, everybody.
Thanks, John.